Hey everyone, thanks for coming back. Just kicking back here, listening to some trance. PSY Radio FM. PSY Trance. I don't know what it is. Anyway, I do listen to a lot of radio. Let's get to it. Today we're looking at firecracker.com, and we're going to be looking at infantile spinal muscular atrophy. So we're going to be reading through Firecracker. I think I may have put the wrong title on there. I'm going to change that right after. So I belong to Firecracker, and I'm also a member of Osmosis. And occasionally I poke around other places, but those are the main ones I look at. These are great in addition to the readings and case studies to prepare for your tests. So let's get right to it. Infantile Spinal Muscular Atrophy. SMA is a lower motor neuron disease characterized by selective loss of anterior horn cells and motor nuclei in the brainstem. So that's darkened out. Remember, selective loss of anterior horn cells and motor nuclei in the brainstem. Infantile SMA or Wernicke-Hoffmann disease is the most common form of SMA and most rapidly fatal. It is an autosomal recessive mutation in the SM1 gene, the survival motor neuron, which leads to a loss of motor neuron survival protein that is critical in development. The loss of large motor neuron causes progressive muscle atrophy, weakness, ultimately respiratory failure. In patients with SMA, there is proximal muscle weakness that is greater in the lower limbs when compared to the upper limbs. Deep tendon reflexes are absent or decreased. Some cases of infantile SMA present in utero with decreased or loss of fetal movement in the third trimester. Infants will have severe or symmetric flaccid paralysis with possible multiple joint contractures in those with the prenatal onset. Upper facial muscles and eye movements are normal due to upper cranial nerve sparing. And the lower facial nerves are involved, leading to poor suckling, poor cry, poor swallow reflexes, tongue fasciculations, pooled secretions, leading to likely aspiration. Respiratory insufficiency is restrictive and progressive. Intercostal muscles are affected more than the diaphragm, leading to paradoxical breathing movements and the formation of a bell-shaped chest. The diagnosis of SMA is made clinically by poor strength, suck, cry, and swallowing. Electromyography, nerve cell conduction studies, and muscle biopsy can be used for confirmation. Electromyography shows abnormal spontaneous activity, while nerve conduction can be normal or mildly decreased. Muscle biopsy demonstrates a mixture of atrophic, and hypertrophic muscle fibers. The hypertrophy occurs after reinnervation of surviving neurons. Although newborns may only show widespread atrophy, requiring a later biopsy to identify the mixture of fibers seen after reinnervation. Molecular testing confirms the diagnosis by revealing homozygous deletions in the SMN gene on chromosome 5. And the treatment of SMA is largely supportive therapy and prevention of or treatment of muscle weakness complications. While there is no proven cure, some evidence suggests that aggressive management targeted toward nutrition and respiratory support can extend the survival period. Experimental evidence shows promising potential for gene therapy using a viral vector to deliver the missing SMN gene in newborns with SMA. So if you look at Firecracker, what they do is they darken out the important points, and starts out straight out by saying selective loss of anterior horn cells and motor nuclei in the brainstem. And remember, it leads to respiratory problems and So I wonder if you can hear the baby crying upstairs, thanks to the neighbors. Sponsored by the neighbors, crying baby. Much appreciated. Driving me crazy. All right, well, thanks for tuning in. Come back again.
This is Med School Radio.